My name is Divya, and today I'll be talking about our paper, Fast Structured Clinical Documentation via Contextual Autocomplete, which is work out of both Beth Israel Deaconess Medical Center and MIT. Clinicians currently spend more time documenting information in electronic health records than they actually spend communicating with patients, and this time sink is posited to be a leading cause of both physician stress and burnout. Consequently, clinicians have adapted to this by using natural language and free text to create their notes, but the resulting clinical documentation is then quite messy, in that it's narrative and unstructured, it contains domain specific jargon, and it also has inconsistent definitions and overloaded acronyms. Overall, EHR data is unstructured, noisy, incomplete, and ambiguous, and this primarily affects three parties: patients who can't understand medical jargon, physicians who have trouble retrospectively disambiguating between these overloaded terms and acronyms, and finally, learned algorithms that rely on structured data to make their intelligence predictions. We propose contextual autocomplete, which is a method of capturing clinical concepts at the point of care via learned suggestions. As you can see here, as the doctor is creating his or her note, we are creating a semi structured representation of the note at the point of care while decreasing documentation burden. So the physician is typing less to achieve the same note. All tag concepts are normalized to clinical ontologies like UMLS. We use multiple sources of information in our contextual autocomplete models, including prior notes from the medical history, as well as the triage assessment and chief complaint. Clinicians can document multiple types of concepts using the language that they're used to. Here you can see clinicians documenting conditions, medications, symptoms, and labs using the language that they traditionally would, like HTN and AFib and other abbreviations for common concepts. Our language model is a two-step process where we first use the local context of what the doctor has just typed to predict when we want to show the autocomplete dropdown, as well as what concept type is about to be documented. Then we use the past data, including the triage note and EHR data, to rank the suggested terms to autocomplete for each concept type, which we then display. Overall, we dramatically reduce the keystroke burden, or the amount the doctor needs to type to create a concept, of data entry in live settings across all concept types. Contextual autocomplete curates labeled clinical data at the point of care while simultaneously decreasing documentation burden. And there are myriad future directions to take this in, but one particularly promising one is how we can use this to enable better clinical decision support. So that could mean aggregating a lab trend once a doctor has tagged a lab like glucose in a note, or it could mean using already documented information like hypertension to pre-fill in later sections like the medication section and reduce redundancy. Overall, we believe that contextual autocomplete can act as a cornerstone of an intelligent EHR that finally works for doctors. And if you're interested in learning more, check out our poster and paper and let us know. Thank you.